Mrs. R, 62-year-old, resident of Baroda, well-educated till master's, teacher by profession, wife of Mr. Y, 70 years old teacher, belonging to the upper middle class according to the modified Swami scale. She visited us for examination on 12th of May with an LMP of 10th May to 2019, and she's an Alipara. She came with the complaint of spotting per vaginum on and off for 1 month. History of present illness. Patient is menopausal since 3 years, and the patient was apparently all right 1 month back. Then she developed complaint of spotting per vaginum on and off. Spotting occurred for 2 to 3 times per day. 3 to 5 episodes of staining have been seen since last month, and only undergarments were stained. No pads were required. No associated history of foul smelling discharge. No history of any hormonal replacement therapy or topical application or any intake of anticoagulant. No history of any vaginal pessary use. No history of genital trauma, ulcer, or any surgery. No history of blood and urine burning, micturition, increased urinary frequency. No history of bleeding per rectum. No history of pain during defecation or any abdominal distension or nausea, vomiting. No history of easy fatigability, weight loss, decreased appetite. There is no history of any lump in the breast or in abdomen. Menstrual history, her last menstrual period was 10th May 2019. She is postmenopausal since 3 years. Her menarche was 12 years of age, and her menopause is around 58. Previous cycles were normal, regular, of 28 to 30 days. 3 to 4 days normal flow was there, and she used 2 to 4 pads per day. There is no complaint of dysmenorrhea or passage of clots. She's married for obstetric history. She's married 40 years back, sexually inactive since 10 years. She's nullipara by choice. History of contraceptive use for 10 years. She was taking oral contraceptive pills. She underwent tubectomy 15 years ago. Past history, she's a known case of hypertension since 20 years on oral drugs, amlodipine 5 mg OD. She's a known case of diabetes on glucagon 500 milligrams, and sugars are under control. No other medical or surgical illness. There is no history of any bleeding disorder. There is no history of any blood transfusions in the past. Family history, no history of breast, colon, or ovarian cancer in the family. Personal history, she's a vegetarian. Sleep-wake cycles are normal. Bowel bladder is normal. There is no history of any allergen or addiction, and there is no history of any cervical canal surgeries. On examination, patient is well oriented.
We'll do the examination later. So summarize your case history, please.
Okay, ma'am.
Only the positive findings with the age, parity, and menopausal status to begin with.
Yes, ma'am. So Mrs. X, 62-year-old of higher socioeconomic status, nulliparous, postmenopausal woman, presenting with complaint of bleeding per vaginum on and off for past 1 month. She attained menopause at the age of 58 years. She is a known hypertensive and diabetic. On examination, the patient is okay.
Don't go to examination, please. I'm not. I've asked you to just summarize the history, right? So you should also tell me what you're thinking of, what comes to your mind. See, always when we take history, it's basically to make us realize, what could be wrong, right? Yes. You have taken some history now. It's basically a case of postmenopausal bleeding. So what is your top 3 provisional diagnosis by history?
Ma'am, since she is perimenopausal, she occurred 3 years and she's having a bleeding. So I'm expecting either any of the malignancies, cervical or endometrial, or there could be endometrial hyperplasia, or there could be atrophic endometritis.
Okay, with whatever history you have presented, it looks like a very perfect case for endometrial cancer, right?
Yes, ma'am.
Okay, tell me all the points which are going in favor of endometrial cancer in this patient.
Ma'am, she is a 62-year-old, so the age, then she is perimenopausal, postmenopausal 3 years, then she belongs to a higher socioeconomic status, and also she had an early menarche and she has a late menopause, and she is a known case of hypertensive and diabetic as well. So
previous cycles?
Ma'am, previous cycles were regular. There was no history of any irregular bleeding.
How was her menopause?
Sorry, ma'am?
How was her menopause?
So ma'am, menopause occurred over a year, and she had cycles which They were not irregular, they were regular, but the quantity of bleeding stopped eventually, and over a year they completely ceased.
Okay. So the important risk factors in this patient basically are a delayed menopause.
Yes,
Okay.
ma'am.
58 years is too late, even with the current standards of menopause being transitioned to like 55, around 55. 58 is too late. Okay. And one more important point is she's nulliparous.
Yes, ma'am.
Right. I think you presented somewhere as tubectomized, right?
Yes, ma'am. She's too.
Tubectomy, I mean, she just didn't want to have children. That's all.
Yes, ma'am.
Usually, it's not that easy to do tubectomy for a nulliparous woman. We'll ask them to generally use.
Wow.
But anyway, this is a history I've got, that is fine. Okay, so now can you describe a patient who by history will look more like carcinoma cervix? These are the top two things whenever you have postmenopausal bleeding. Okay, they are the two most things we have to exclude.
Yes, ma'am.
Okay. But what is the most common cause of postmenopausal bleeding according to you?
Ma'am, most common cause is endometrial cancer.
No. Why, you living in US or India?
Ma'am, India. Oh, sorry, cervical cancer.
Right. So, cervical cancer is the most common cause in hospital-based settings. Please remember. Okay. If you go and explore in community-based setting, the atrophic endometritis is going to be the most common cause of postmenopausal bleeding. Okay. But that particular bleeding is minimal, first of all, and self-limiting. Many times patients will notice one episode and they may not even notice the next episode, like, because it will be very minimal spotting, which may be not wearing pads or panties or something like that. Most of them really do not, right? So atrophic endometritis is one of the important causes of postmenopausal bleeding. Remember, the only thing is it is self-limiting and very minimal, so people generally do not come to hospital. Otherwise, in our country, the most common cause of postmenopausal bleeding is carcinoma cervix. Okay. But incidence of carcinoma endometrium is increasing in our country also, but it is 10 times lesser than in Western countries. Okay. How do you explain this? Why? First of all, tell me, why do you think the incidence of endometrial cancer is increasing in our country?
Ma'am, because of the, ma'am, it is endometrial cancer is basically seen in a higher class because of the metabolic disorders, association with the metabolic disorders, and there's a rise in metabolic disorders like hypertension and diabetes in our country because of the lifestyle which is changing. So
adaptation of Western lifestyle. Okay, our eating habits. You can see there is a significant change in our eating habits now. Okay, so probably another 20-30 years down the line, our endometrial cancer incidence may get doubled also, because all these pizza joints and burger joints are not helping it at all. Right? They are high calorie foods, and we are adapting to a sedentary lifestyle like Western countries. It is not like before. Right? So the incidence is slowly rising. It is on the rise. Okay, and obviously the incidence is much more in metros when compared to rural areas.
Okay, ma'am.
So now we'll go back to the question what I asked you. The way this patient is typically fitting into endometrial cancer, tell me the patient profile which will fit into carcinoma cervix.
So, ma'am, for carcinoma cervix, there will be other presentation as well, like blood stain, vaginal discharge, or foul smelling, purulent discharge will be there. And apart from
start from the beginning. Okay.
Okay.
Menopausal status is it's a risk factor for both the cancers. Okay. Yes, what comes after that age in menopausal status? In between that, actually, one more important
early menarche
factor. No, demographic factor.
Demographic factor. Parity. Yes, ma'am. Parity.
So multiparity. Multiparity goes more in favor of cervical cancer for us.
Yes, ma'am. Yes.
So when you're describing the typical patient, you have to remember all these things. Okay. It will be again, and there is a bimodal incidence of carcinoma cervix. Okay, we have ones in the end of 30s and another in the postmenopausal women around 60s. Okay, so we know that there is a bimodal peak. So A is fitting into carcinoma cervix here. The menopausal status is fitting into carcinoma cervix. Okay, but the parity is not going very much in favor of carcinoma cervix. Early menarche is not a risk factor for carcinoma cervix. Tell me, what is risk factor for carcinoma cervix?
Ma'am, risk factors for carcinoma cervix involve ma'am, infection, HPV infection.
How do you get it from history, my HPV infection? It's not possible, right?
Yes.
You have to tell me the factors which will increase the risk of HPV infection. And
early coitus, early age of coitus,
early
childbirth.
early childbirth, these are the risk factors. Okay, not early menarche.
Okay.
So early menarche is a risk factor for endometrial cancer, breast cancer, ovarian cancer. Okay, but not for cervical cancer. Cervical cancer, it's basically early coitus and early childbirth. Okay, and multiparity. Okay, multiple childbirths and multiple sexual partners. Okay, so basically all these will increase the chance of them acquiring HPV infection, and it will also increase the the risk of HPV integration into the host DNA. Okay, so you should know just HPV can't. You're a postgraduate or undergraduate?
I'm postgraduate.
You're postgraduate. Okay, fine. So you'll have to think about the factors which will increase the risk of integration of the HPV genome into the host DNA. Okay, so these are the 4 important risk factors. Then we have other co-carcinogens like low hygiene and other STDs and cigarette smoking. Okay, all these will increase. It will increase the risk of integration of the HPV into the host genome. Okay, so a typical patient will be basically a woman belonging to lower socioeconomic status. Okay, multiparous woman, postmenopausal woman with early childbirth and early exposure to coitus. Okay, you need not think about multiple sexual partners in all the women. First of all, you might not get the history also. It's a very sensitive area there, right? So we don't really worry much about it. Now let's go back to this particular case. Tell me one factor in your history which is not a risk factor, which is not actually increasing the risk of endometrial cancer.
Ma'am, use of history of contraceptives, oral contraceptives.
Oral contraceptives, especially 10 years of oral contraceptive should reduce the risk of endometrial cancer significantly. Okay, even 5 years is known to decrease the risk by half. So 10 years should be actually decreasing it a lot actually, but it didn't happen here, probably because of some other reasons. Doesn't matter. What is the importance of age when you talk of endometrial cancer?
Ma'am, it is more common above 55 years of age to 70 years of age.
Anything else? Well, if you're seeing an endometrial cancer in a woman who is less than 40, what will you think of?
Ma'am, it is less.
Not very common, right? Very few, less than 5% of endometrial cancers actually occur in younger women. Okay, so you should think of familial cancer syndrome. Okay, Lynch-2 syndrome. Okay, so when a younger woman comes, you have to keep in your mind to rule out Lynch syndrome and look for either genetic testing or immunohistochemistry testing for mismatch repair genes. Okay, so this is very important because it will have treatment implications later on in endometrial cancer. Okay, so that is one thing you should remember. Okay, about the age. And another important thing is if you're finding endometrial cancer in a patient who is more than 75, 80s, more than 70s and all, what will you think of? Generally not the very common age, right?
Yes, ma'am.
So what should come to your mind if you're finding endometrial cancer in a woman who's more than 75 years of age?
Ma'am, again, familial cause?
Familial usually presents early, it won't present late. Okay, if you're finding endometrial cancer late in this thing, you have to think of type 2 cancers. What are type 2 endometrial cancers?
Ma'am, clear cell cancer, serous cell carcinoma.
Serous cancers, okay? So they are not estrogen dependent cancers.
Yes, ma'am.
So they occur a decade later than your type 1 cancers. Okay, that is the importance of age for you. Please remember these things. Okay, if you see in young age, think of familial cancer syndrome. If you see in very old age, think of type 2 cancers. Okay, and general age is around 55 to 60 years. In the perimenopausal age group or slightly just postmenopausal age group, we'll see this particular type 1 cancers which are estrogen dependent. Okay, the basic pathology in endometrial cancer is unopposed estrogen exposure without any action of progesterone. See, if you're seeing it in a younger lady, nowadays we're seeing too many women who are nulliparous being worked up for infertility, where they have done an endometrial biopsy for AUB and they find it is endometrial cancer, less than 40. Okay, the incidence is increasing surely because there is a component of chronic anovulation, typically in PCOD patients. Okay, so this chronic anovulation will lead to unopposed estrogen action on the endometrium, which will lead to endometrial hyperplasia, and then it will become endometrial carcinoma. Okay, Tanvi, can you tell me something about endometrial hyperplasia?
Ma'am, endometrial hyperplasia is growth of the stromal component of the endometrium And it is earlier it was classified as simple with atypia, complex with atypia, simple without atypia, and complex without atypia. And but now we just take it as with typical features or with atypical features, and the chances of conversion of atypical into parts.
Features, sir.
Yes, ma'am.
It is not classified as typical features. It is classified as with atypia or without atypia. That's it. Okay. That's the exact term. The WHO has recently classified it into only two. What is the risk of hyperplasia with atypia progressing to malignancy if untreated?
Ma'am, 27% around.
25%. Okay, good. So basically, type 1 cancer is the one which is preceded by these hyperplasias. Please remember that. Okay. Type 2 cancer is not known to be preceded with hyperplasia. It's actually seen in the background of atrophy. Okay. So that is about your history. How will you go about actually? But generally, whenever you think of a malignancy, always ask about negative history of symptoms suggestive of metastasis.
Yes.
Of ovarian cancer, or endometrial cancer, or cervical cancer, know what are the common sites of metastasis for each cancer and ask for relevant history. Okay, you are thinking of endometrial cancer over here. Okay, so the most common site of distant metastasis is going to be lungs. So you will ask about any history of dyspnea or any history of hemoptysis. Okay, liver also can get affected, so you'll ask about history of any jaundice. Okay. Brain, bone, anything can get affected. So you have to have one sentence somewhere about there is no history suggestive of metastasis, distant metastasis like. Okay, if you are thinking of malignancy as a topmost diagnosis, then you have to comment about history of metastasis. Okay, suggestive of metastasis. Okay. Go on to the examination.
Ma'am, general examination.
Okay.
Yes. Patient is conscious, well-oriented with time, person, and place. She is heavy-built. BMI is 32. There is no pallar cyanosis, clubbing, or lymphadenopathy. There is no edema. Pulse is 82 beats per minute in right radial artery with good volume character. No radiofemoral delay. All peripheral pulses are present. Her BP was 140 by 110 in right arm in sitting position and repeated after 15 minutes. Found to be same. Respiratory rate 16 per minute, and she is afebrile. JVP is not raised, spine is normal, and bilateral breast examination is normal.
Stay here. Yes, stay here. Stay on the same slide, please.
Okay.
See, in general examination, it's good to be thorough. Okay, but you should also let the examiner know what exactly you're looking for. Understood? See, this fourth point, what you have. No pallor, cyanosis, clubbing, lymphadenopathy. Why will you worry about cyanosis, clubbing and all in this particular patient? Okay.
Clubbing would be basically advanced cancer with mets involving the lung.
Mets and all this stuff, probably yes. Okay, but very unlikely, right? Before even you comment, and lymphadenopathy is a very generalized thing. You have to be more specific about
which type of lymph nodes. Yes, ma'am. So I should have checked for supraclavicular lymph nodes and inguinal.
Supraclavicular and
inguinal.
Even axillary. Okay, axillary also we will look for, but you have to be specific about no supraclavicular lymphadenopathy. There is no inguinal lymphadenopathy because that is something which comes in the staging for us, right? Inguinal lymph nodes involved will be which stage in endometrial cancer?
Ma'am, stage 4B.
It's 4B. Okay, so you know that that's important, right? So you should specifically mention. Just see, this looks like as if you have just done it for completion's sake. Okay. So you should let the examiner know. Yes, I know what I'm looking for. Okay. Edema. Edema is one more thing. Tell me, where do you see edema? In which gynec malignancy is edema common?
Vulval cancer.
Vulvar cancer. Okay. Other than that, wherever there is significant lymphatic involvement, like any cancer where there is significant pelvic and para-aortic lymph node involvement, there also we can see edema. But other than vulva, one more important thing is in ovarian cancer. Because their malnutrition is significant and because of hyperproteinemia, they'll have edema. Okay, so specifically you look for edema in these conditions. In endometrial cancer, in general examination, you should look for signs of insulin resistance.
Yes.
Especially if you're seeing it in younger population, not in older population like this. But generally, if you see it in younger populations, you look for acanthosis nigricans. Okay, other signs of hyperandrogenic status like acne, hirsutism, all those things, frontal baldness should come. Okay, so I've seen your slides. You've written as endometrial cancer as your probable diagnosis. That is why all this becomes important. Okay, at least when you finish your examination and you think it is not cervical cancer, it looks like endometrial, go back and mention about all those things. Okay. Otherwise, it looks okay. Go on. Next.
Ma'am, systemic examination, cardiovascular findings, apex beat in the fourth intercostal space in the left anterior axillary line, S1, S2 normal, there were no murmurs. Respiratory system, air entry bilaterally equal and no additional sounds are heard. And CNS, no sensory motor defects and deficits and all reflexes are normal.
Okay.
Now, ma'am, local examination, external genitalia, vulva looks healthy.
No, abdomen examination. Abdominal examination? You skipped a slide or you didn't mention?
No, ma'am. I did not mention.
You should. Okay. Yes, so, why is abdominal examination so important? Why did I specifically ask?
Because lump, any feeling of any lump in the abdomen is important, and any tenderness is important.
What lump are you worried about?
Ma'am, it could be Mets or it could be ovarian. Ovarian.
For example, uterine size. Okay. The uterine size generally, if it is more than 12 weeks only, then we'll be able to appreciate for up to that. Yes, so, other than the uterine size, okay, which can denote something in cervical cancer, especially. What does it denote? If the midline there is an enlarged uterus, what does it denote in cervical cancer? A patient with CS cervix has an lower abdominal mass. What does it denote?
Ma'am, involvement of the
pyometra. Okay. Fine. If you think the uterus is enlarged, especially in cervical cancer, always think of pyometra. Actually, in cervical cancer, they will ask you what exactly do you look for in abdominal examination. One is pyometra. Okay. Other one is the enlarged ilia group of lymph nodes, because generally cervical cancer is not a disease of obese women. These women will be thinner, belonging to lower socioeconomic status and all. So, the enlarged ilia group of lymph nodes can be palpated in the iliac fossa sometimes. Okay. Other than that, another important thing is hepatosplenomegaly. Any cancer abdomen you can't skip, because if they have developed metastasis, there will be hepatosplenomegaly, right? Okay, so that should come. And in cervical cancer especially, also look for renal angle fullness, because hydronephrosis is pretty common in cervical cancer. Okay, that is how your abdominal examination becomes important. Now, let's assume you have this endometrial cancer. Your provisional diagnosis is endometrial cancer, and there is a lateral mass, okay, an adnexal mass. Okay, yes. Just give me a moment, Tanvi. I'll just. Okay, Tanvi, can you hear me?
Yes, okay.
So, basically, what was I saying?
Ma'am, there is a mass in the lateral adnexal.
Yeah, so if there is an adnexal kind of mass, in a lateral abdomen, you're able to feel a mass, and your provisional diagnosis is endometrial cancer. What will you think of? An ovarian mass with endometrial cancer. Right? You got the point?
Yes, ma'am.
So, which ovarian mass can be associated with endometrial cancer?
Ma'am, granulosa cell tumors, epithelial cell tumors.
Estrogen producing ovarian cancers can lead to endometrial cancer, right? So, you should always examine the abdomen. Okay? You understood?
Yes, ma'am.
Now, go to the examination of the genitalia.
Ma'am, external genitalia looks healthy. Urethral opening is normal. Anal opening is normal. On first speculum examination, cervix and vagina look healthy. No atrophic changes in the vagina. And
okay, stop there.
Yes, ma'am.
Stop there. Go back to the slide. First speculum.
Yes, ma'am.
Okay. First speculum, cervix, vagina is healthy. Cervical cancer is almost ruled out. Asymptomatic cervical cancer, yes, right?
Yes,
tell me, if it is cervical cancer, what are the different types of, what do you say?
Growth.
Cervical lesions you will see. Morphological cervical type, basically, morphological types of cervical cancer.
Ma'am, we can see an ulcerative type of growth, or a proliferative type of growth, or an endophytic type of growth.
So, proliferative is basically exophytic. Exophytic. The most common is actually something called as ulceroproliferative. Okay, yes. Both mixed up. Okay, endophytic basically it'll just look like an hypertrophied cervix. It's more appreciated on palpation than inspection. Okay. So generally what we see, the cauliflower type of growth, what we describe is a proliferative exophytic growth, which is ulcerated on the top. So it will look like a cauliflower kind of growth. Okay. And one more type of cancer. It is cervical cancer, but a rectocervix looks normal. So but it can be endocervical cancer. What will be the morphological appearance of endocervical adenocarcinoma? See, a lesion is entirely in the endocervical canal. Okay. Barrel-shaped cervix. Okay, so that is barrel-shaped cervix is somewhere where the ectocervix is apparently normal, but endocervix is there is a growth in the endocervical canal. Okay, so that is what is the morphological different types you can see when you have actually cervical cancer. If everything looks perfectly fine, okay, cervix vagina is healthy, there is nothing, then obviously you won't think of cervical cancer. But if you are examining this patient in OPD at that point of time, what will you do? You put in a speculum, you find the cervix vagina is healthy. What will you do at that point of time? If you are examining this patient,
pap smear will take a pap smear.
But please remember, pap smear you will take only if there is no active bleeding through the os. Otherwise, it will mask your findings, right? So if the bleeding is not very significant, okay, you can take a pap smear at that point of time. Then you will proceed with the bimanual examination. Go on.
So, ma'am, per vaginal examination, cervix is down and forward and smooth. No atrophic changes in vagina. Uterus is anteverted.
Vaginal in palpation, how do you say no atrophic changes in vagina? You already mentioned it in the per speculum, right? You mean rugose well maintained and there is no atrophic changes. So this is a per speculum finding, not per vaginum finding. Okay.
Yes.
Go on.
Uterus is anteverted. Size is not made out due to the obesity. It is uniformly enlarged, firm in consistency. It is non-tender and mobile. Bilateral fornices are free. No tenderness is seen and they are mobile.
Okay. Go on.
Ma'am, per rectal examination, rectal mucosa is free, bilateral parametrium is free, and no nodularity is seen in the pouch of Douglas.
Stay here, Tanvi. Why did you look for nodularity in pouch of Douglas?
Ma'am, any kind of spread.
How does CA endometrium or CA cervix spread? What is the most common mode of spread of CA cervix or CA endometrium?
Ma'am,
contiguous spread, right? That is, it will just spread to the adjacent tissues. From endometrium, it will go to myometrium, or it will come down to cervical stroma, then it goes to either vagina or parametrium. Right? There is no nodularity in the pouch of Douglas issue in cervical cancer and endometrial cancer until and unless you have a type 2 cancer. Type 2 cancer can spread like ovarian cancer. So there we can see nodules in pouch of Douglas. Okay. So nodularity in pouch of Douglas, you generally won't mention if you're thinking of cervical cancer or endometrial cancer. You'll only mention about parametrium being involved or not involved, rectal mucosa. That's it in PVR. Okay. Go on.
Summary. Mrs. X, 62-year-old of high socioeconomic status, nulliparous postmenopausal woman with complaint of bleeding per vagina on and off for past 1 month. She attained menopause at age of 58 3 years ago. She is a known hypertensive and diabetic. On examination, she is obese with BMI of 32. She has mild pallor and her BP is 140/90. Abdomen is soft. Per speculum reveals that the cervix is healthy and there is no active bleeding through the os. On bimanual examination, uterus is bulky, uniformly enlarged, anteverted, mobile, and fornices are free. On rectovaginal examination, parametrium is free.
Okay.
Yes, ma'am. Provisional diagnosis: 62-year-old nulliparous woman with postmenopausal bleeding with grade 1 obesity with hypertension and diabetes for evaluation of endometrial bleeding. Endometrial cancer could be the first differential diagnosis as she has the risk factors of nulliparity, obesity, hypertension, diabetes, early menarche, late menopause.
So how do you proceed? You think it is endometrial cancer, right? So what
we'll do a basic assessment. We'll do basic investigations like CBC, blood grouping, all the serum.
No, you don't even have a diagnosis, right? So what's the point of investigator with all these things? When somebody asks you what is the next step,
okay, ma'am. So next step we'll take this as a transvaginal sonography. We'll prefer to do a sonography.
First thing you will do. Okay. Yes, sometimes you may even take an office EB without even doing ultrasonogram. If you are sure that everything is fine, you've taken a pap smear. then you may go for direct pipal endometrial biopsy.
Endometrial biopsy.
But you should not say I will do hemoglobin or CBC or something like that before you even know what you're dealing with. Right? You have to have a diagnosis first. So whenever you, for example, you have an adnexal mass and I ask you, what is your next step? You'll say probably ovarian malignancy. And if I ask you what's the next step, you should not say CBC. It doesn't make any sense, right?
Yes,
you should say I'll do an imaging. Basic imaging, what we do is an ultrasonogram. Like that, here it is going to be a transvaginal ultrasonogram. Okay. So you will do that. What exactly are you looking for in transvaginal ultrasonogram?
Ma'am, we're looking for the endometrial thickness.
Okay.
Then
What's
we are
the
looking
cutoff
for
of endometrial thickness?
ma'am 4 mm.
Anything more than 4 mm is abnormal for us, and we need to further evaluate her. Okay. What if this patient's endometrial thickness comes as 3 mm?
Ma'am, we will not proceed to endometrial sampling right now. We would wait. If in this patient, since the high risk factors are present, we will do it. But if otherwise the risk factors are not present, we can let her go and repeat the sonography after 3 months.
No, you will generally what we do is if you find that endometrium is not appearing thickened, it is very thin endometrium, there we will counsel the patient to observe. If the bleeding is not settling at all, it is recurrent bleeding. Okay, then we will do a endometrial biopsy surely. Okay, if the bleeding settles, there is no further problem, we'll see her after 3 months and do a repeat TVS and we'll just put her on follow-up, that's all. Okay, so basically it is the recurrent nature of the bleeding which will make us intervene in these women. We can't ignore recurrent bleeding. Okay, so basically in this patient, let's assume the endometrium is around 10 millimeter or 12 millimeter. Okay, what else we'll look for in the TVS?
Ma'am, we look for the thickness and then we will look for this. We look for the regularity of the endometrium. We look for the ecogenic structure, endometrial ecogenic structure, and we will look for if there are any localized lesions which are usually fed by a single artery. So, like any localized lesion of either polyp is present or any other growth is present.
Look for endometrial thickness, number 1. Number 2, you look for endomyometrial junction interruption.
Yes, ma'am.
Okay, you will see whether the endomyometrial junction is well maintained or you feel that it is disrupted.
Yes, ma'am.
Okay, that is number 2. Then you will see whether there is obvious, involvement of the cervix. It can be easily appreciated on a good transvaginal ultrasonogram. Then you will look for the adnexa. Okay, these are the 4 things you can make out in the TVS. Nowadays, we don't really require MRI for checking the myometrial invasion. Okay, subjectively we can assess the endometrial, in myometrial invasion in endometrial cancer using the transvaginal ultrasonography also. Okay. So these are the things you will see for in TVS. Okay, once you know that endometrial thickness is 10 millimeter, what is the next step?
Ma'am, if we know that it is 10 millimeter, then we'll see if it is regular or if it is not regular. So if it is a regular, if it is irregular, we'll either go for a endometrial aspirate or we'll go for a hysteroscopic biopsy.
Yeah, generally endometrial biopsy, the office endometrial biopsy using the pipils is very well accepted for diagnosing the endometrial carcinoma nowadays. Initially, we used to do a fractional curettage or a dilatational curettage, whatever. Nowadays, they don't recommend all those invasive stuff. They say just an endometrial biopsy is enough. But as you rightly said, if your endometrium is looking like focal, okay, there is a focal lesion. It may be a polypoid lesion which is turned malignant or something like that. You may not hit it in endometrial biopsy. So there it becomes important to do a guided biopsy. Guided biopsy is obviously using a hysteroscope. Okay. What is the concern about use of hysteroscope in suspected cases of endometrial cancer?
Ma'am,
is there any concern?
Sorry?
Is there any concern of using hysteroscopy in a suspected case of endometrial cancer?
Ma'am, spread, it might lead to spread.
That was a theoretical concern, obviously, because you'll be using a distension media. You'll increase the pressure in the endometrial cavity. It may lead to spillage of the fluid containing the malignant cells through the open tubes if they're not tubectomized, or it may lead to increased extravasation into the venous system itself, right? So these were all theoretical concerns initially, but then they were not proven by studies. So hysteroscopy is an accepted mode of diagnosing endometrial cancer wherever you're suspecting a focal lesion, and it's actually a gold standard. Okay, but the first choice is endometrial biopsy, not hysteroscopy. Hysteroscopy is not available in all the places, right? It is an expensive investigation. So just an endometrial biopsy using pimples is the first mode of diagnosis. If your pimples comes negative, okay, endometrial thickness was 10 millimeter, but your pimples comes negative, then you will go ahead and do either a guided biopsy. If you don't have hysteroscope, go for a thorough dilatation and curettage. Okay, that is what we do for diagnosing endometrial cancer. Okay, now what is the most common histopathology you will see when you do a EB?
Ma'am, most commonly we'll see endometrial hyperplasia.
Can we stop sharing? We're not going to discuss the management.
Ma'am, we'll look for endometrial hyperplasia, most common.
Most commonly?
No, atrophic changes. Atrophic endometrium.
I didn't get, what are you telling?
Ma'am, you're saying after doing the endometrial sampling, what kind of a scenario we'll see?
No, your suspicion of endometrial malignancy, right? I'm asking you what is the most common histopathological type of endometrial malignancy you get if it is endometrial cancer?
Ma'am, adenocarcinomas.
So, endometrioid adenocarcinoma. Adenocarcinoma can be two types in uterus. Please remember, endocervical cancer also is adenocarcinoma and endometrial also is adenocarcinoma. So, they were to be very specific as endometrioid adenocarcinoma. Okay. How do you distinguish between these two entities? You get an adenocarcinoma, okay, your disease can be in the endocervix or it can be in the endometrium. Okay, how do you know whether it's arising from endometrium or from endocervix? Is there any way we can make out?
Ma'am, on histopath slide, we can make out the differentiation from the tissue.
Morphologically, yes, probably you'll see the glands and all those things fine, but what's more important is something called as immunohistochemistry. You've heard of it?
Yes, ma'am.
Look for the hormone status. ER/PR status is positive only in endometrial. Okay, not in cervical cancer. And all these cervical cancers are associated with HPV, right? So wherever there is HPV affection, it will lead to P16 positivity. So endocervical adenocarcinoma is going to be positive, and endometrial is basically positive for ER, PR, and Vimentin. Okay, Vimentin is a marker of endometrial. Okay, so basically, endometrial cancer will have these three things positive, and endocervical will have positive. That is how we usually distinguish. Surely, whenever there is a doubt whether it is endocervical malignancy or endometrial malignancy, because your lower segment lesions can mimic an endocervical cancer. Okay. So that is what we do in histopathology. Okay. So now, what else you will see on the histopathology now slide when they give a report? Other than the type of malignancy like endometrial adenocarcinoma, what else they can give the information about?
Ma'am, grading of the cancer. How much is the non-squamous component
for us? Okay, because we can risk stratify the patients depending on the grade of the. Okay, whether it is grade 1 or it is high grade. Okay, if it is grade 3, it will go into type 2 cancers again because it's extremely high risk and the management is entirely different for low grade and high grade patients. Okay, going to the management today, it's not possible to cover both. So let's go back to the second scenario. You put in a speculum and you find that there is a growth on the cervix. What do you do next?
Ma'am, we try.
Can you please mute other participants? No disturbance. Nandini, can we use a sound from your side?
Yes, ma'am.
What is it?
Ma'am, it's in the background.
Okay, go on. Can you hear me?
Yes, ma'am, I can hear you.
Yeah, tell me.
Ma'am, if we find a mass in the cervical region, we'll try to take a biopsy.
What do you mean try to take a biopsy?
We'll take a biopsy.
I've asked you one question. Your answer should be complete. Tell me what will be the complete answer for this. Biopsies can be so many types, right? So what type of biopsy we use for cervical cancer? Where will you take the biopsy from? All those things should come in your one answer. Okay. So what do you say?
We'll take a punch biopsy from the edge of the lesion.
Edge of the growth. That is the correct answer. Just not say I'll take a biopsy. Okay. It has to be, because if you just go and take a biopsy from the center of the growth, you'll get necrotic tissue. So again, your answer is not very exact. So you have to be proper. See, the way you answer your questions will give an idea to the examiner that she knows what she's talking. Okay, so it has to be punch biopsy from the edge of the growth. Okay, now tell me, how do you diagnose stage 1A cervical cancers?
Stage 1A cervical cancers. Ma'am, they are diagnosed only on microscopy.
But how do you diagnose? See, you won't be able to see any lesion, right? There is no gross lesion on the cervix. So where it
ma'am, yes, ma'am. We'll do the acetic acid test and we'll see the white areas and we'll take the
for a stage 1A cancer is either an abnormal pap smear or abnormal VIA.
Yes, ma'am. Visual.
There is no gross lesion, so either you diagnose an abnormal pap smear and then you subject the patient to colposcopy and then diagnose, or you do a VIA, you find an osteocyte area and then you go and take. Okay. Can you tell me what causes osteocyteness of the area, abnormal area?
Ma'am, the presence of glucose in the cells.
But that is not for acetic acid, no, that is for Lugol's iodine positivity is because of glycogen in the cells. Okay.
Yes.
Acetic acid is basically the abnormal cells will have a high protein content. You know that nuclear proteins are much more in abnormal cells. You know the increased nucleoside-plasmic ratio, no?
Yes.
So the nuclear proteins are more in the abnormal cells. They get activated when we apply acetic acid. Okay. So you have done a urine test for protein. Now what happens when we heat? It gets coagulated. Do you remember?
Yes, ma'am. Yes, ma'am.
When we apply acetic acid, it will lead to coagulation of the extra proteins. So normal cells have lesser protein than abnormal cells. Okay. So that's why abnormal cells will look whiter. Okay. That is how we identify the osteocyte areas and take a biopsy from them. Okay. So once you have taken a biopsy, again, what is the most common histopathological diagnosis you get on biopsy of suspected cervical cancer?
It will be, ma'am, squamous cell carcinomas.
Squamous cell carcinoma, either large cell or small cell, keratinizing, non-keratinizing, whatever. Okay. So, and we can also see adenocarcinomas, but they are much lesser than squamous cell carcinoma. Most common is squamous cell carcinoma. So, once you get the biopsy of squamous cell carcinoma, how do you stage cervical cancer? What is staging of cervical cancer based on? See, over here, surgical staging, surgicopathological staging, right? That's how we say. I'm asking you in the similar way, how do you stage cervical cancer?
Ma'am, staging is done, it is clinically staged.
It's a clinical cancer, but recently, the recent FIGO staging also includes?
Ma'am, all the tests and all these to see the lymph node involvement and
includes imaging. Okay.
Imaging, yes.
Otherwise, initially, FIGO never used to allow any kind of imaging other than just ultrasonogram to look for hydronephrosis, okay, or lymphangiography to look for lymph nodes kind of thing. But now they're allowing even CT, MRI, PET CT, whatever. Okay, so that we'll be able to get a definitive staging of cervical cancer. Okay, so I think that's it. The evaluation of postmenopausal bleeding, basically, you have to decide whether it is worth further evaluating. For example, if she just gives history of postmenopausal bleeding and now she's absolutely fine, there is nothing, probably can just do a TVS if TVS is less than 4. Cervix is normal apparently. But anyway, we'll take a pap smear for all the patients. It's an opportunity screening in our country most of the time. So we'll take a pap in that lady. Okay. Otherwise, if you find a cervical growth, you'll take a biopsy. If you find cervix is absolutely normal, you'll do a TVS and then do an endometrial biopsy if the endometrium is thicker. Okay, that's how the evaluation goes on. Management is not easy to discuss in one class. So we'll stop at this point of time. Okay. So you have to reach a particular diagnosis. You should know how will you work up further. That's all. Okay. Once you have a diagnosis of endometrial cancer, again, what will you do next? Okay. How will you decide the extent of surgery? How will you decide the adjuvant treatment? Everything is entirely different discussion. Okay. Even for cervical cancer, once you have the diagnosis of cervical cancer, you will stage and then you will decide what to do, whether to go for surgery or to go for radiation, whatever.